So Abhirami is itching to go. He wants to answer the next question. Okay, go. Go ahead.
My question is anesthesia for release of temporomandibular joint ankylosis in 5-year-old boy with mouth opening less than 1 finger. Temporomandibular joint, articulation between squamous part of temporal bone and head of mandibular condyle. Temporomandibular joint ankylosis, a fusion of mandibular condyle with glenoid fossa, obliterating the normal articulation, immobilizing the mandible. Causes, most common trauma, condylar fracture, hemarthrosis, and obstetric trauma. Inflammation, rheumatoid arthritis, ankylosing spondylitis, and Still's disease. Infections, otitis media, parotitis, mastoiditis, and suppurative arthritis. Surgical post-op complications of post-op complications, meniscal tear, or age less than 10 years, a prolonged immobilization. Then movement of temporomandibular joint, elevation, depression, protrusion, excursion. Topazian staging for temporomandibular joint ankylosis. Stage 1, ankylotic mass limited to condylar process. Stage 2, ankylotic mass limited to extended to sigmoid notch. Stage 3, ankylotic mass extending to the coronoid process. History, we should ask history of any trauma and congenital causes, duration of trismus, extracapsular causes like untreated zygomatic fractures, history of any ear infection in the childhood, any history of forceps delivery of child. Clinical examination, in case of unilateral ankylosis, facial asymmetry, affected side there will be a fullness, opposite side will be a flat and elongated, the chin will deviate to affected size. Reduced condylar movement, decreased mouth opening, and poor oral hygiene. Then in case of bilateral ankylosis, bird face deformity or anticum deformity will be there. Convex facial profile, a retinognathic mandible, class 2 malocclusion, limited mouth opening, and crowding of teeth. When mouth opening is less than 5 mm, there will be complete ankylosis. Associated problems, there will be interference with chewing of food and speech. Psychological problems, poor oral hygiene, and any dental issues. In case of it will be associated with OSA if micronapnea or retinographia is present. Then test for temporomandibular joint function, like sternomental distance more than 12.5 cm will be normal. Thyromental distance more than 6.5 cm will be normal. Hyomental distance between the mentum and the hyoid bone more than 6 cm will be normal. Or upper lip bite test, grade 1, grade 2, grade 3. Goal of surgical treatment, like restore the mouth opening and joint function, allow for condylar growth in case of child, to correct facial profile, to relieve upper airway obstruction. Surgical options include high condylectomy, gap arthroplasty, interpositional arthroplasty, distraction osteogenesis. The concerns in regarding this case, like pediatric and anticipated difficult airway, airway management, fiber optic, plan A will be a fiber optic awake fiber optic intubation with topical anesthesia, which will be gold standard. Plan B, blind nasal intubation. Plan C, tracheostomy or emergency cricothyroidectomy. Or plan D, retrograde intubation. In case of extubation, if they are on a tracheostomy, we can continue with it. In case of nasal intubation, we use a laryngoscope to visualize the epiglottis, then to check whether the reintubation is possible or not. Then, or else we can use a tube exchange catheter. In this case, a pediatric airway, so awake fiber optic intubation will be with inhalation induction with CO, with added IV ketamine 2 mg per kg, IV 2 mg per kg, and IV midas 0.02 mg per kg IV. Other option, IV induction with propofol with regional anesthetic technique supplementation, like superior laryngeal nerve block and transtracheal block.
You finished? Now you mentioned about thyromental distance and so many values, isn't it? It's
Yes,
all
sir.
applicable to a 5-year-old child. A 5-year-old child have a 6 centimeters distance of. So in this sort of case scenario questions in the theory paper, you used to
Okay, sir.
stick to the description of the patient. So here the catch question here is a 5-year-old baby or a child
Okay, sir.
with a limited mouth opening where direct laryngoscopy is next to impossible. So we have to do only a fiber optic intubation, and you can't expect a 5-year-old child to cooperate and listen to whatever you say. So the main answer that is expected when such question is given is, how will you manage a fiber optic intubation in a 5-year-old uncooperative child? That is the main point that is to be discussed. So
Yes.
this is a case of anticipated difficult airway because mouth opening is not there. We have to resort only to the other options. And rightly you mentioned fiber optic intubation, retrograde intubation, or tracheostomy are the three choices that we have for delivering anesthesia to this baby. So how we are going to manage that? That is where you must give more emphasis on your answer rather than trying to classify the type of PN joint ankylosis. All the surgical details are not warranted in your answer paper. You'll be only wasting time writing all those things. Okay. So I'll just show you how to answer that question.